Last week we discussed apraxia of speech. This week we will review dysarthria. Dysarthria is a speech disorder caused by muscle weakness due to brain damage. In children, it is most prevalent with cerebral palsy, or CP. Approximately 75 to 85% of children with CP show obvious speech problems. With adults, however, it is likely a result of a stroke or a brain injury. Prevalence of dysarthria with adults is not fully known, though, as it can vary based on the location of the lesion, the nature, and the course of the underlying condition. Now, when considering prognosis, it is dependent on the cause. For many, it may last for the rest of the patient's life. In some cases, such as after a surgery, the symptoms may improve. However, for some degenerative conditions, a person may in time completely lose their ability to speak. Here is a list of the most common causes of dysarthria in children, with CP being the most common. Joseph Duffy, in 2013, reported this list of neurologic illnesses, diseases, and disorders as causes for dysarthria in adults. Now, these causes are both acquired or developing after birth and then congenital, meaning born with it. As you see, there are many causes for adults. This is not to say that the same condition may not also cause dysarthria in children, but there seems to be more research with adults. Dysarthria typically affects one, a variety, or all parameters of speech, including respiration, phonation, resonance, articulation, and prosody. Overall, it affects the intelligibility of speech, the naturalness of speech, or could be both. There are 6 types of dysarthria resulting from the location of the lesion. The major speech characteristics for each type are listed in your book on pages 315 and 316. Clients with dysarthria portray with decreased strength and coordination of their speech musculature that will lead to distortions of speech sounds. Now, they may also have involuntary motor control for chewing and swallowing due to this same weakness and incoordination. Speech production errors are typically consistent. Now, this is different than what we said for apraxia. With no times of clear, precise speech. Vowels are typically distorted with imprecise consonants, thus causing slurred or mumbled speech. Prosody errors include the client either speaking too fast or too slow, speaking softly based on improper breath support. Their speech may also sound robotic or choppy based on having difficulties understanding or being able to put the stress in. Other errors include that, as I said earlier, their speech is always slurred or mumbled, which affects their intelligibility. Because they have no times of clear speech. Their vocal quality may change as their voice may sound hoarse or breathy. Resonance may be affected, causing hypernasal or hyponasal speech, as well as audible nasal emissions. Pitch level may also be too low or too high, and phonation errors consist of their speech being monopitch or having pitch breaks, also an abnormal vocal quality, and may have difficulties controlling their loudness. So what do we do in therapy? Well, when considering what therapy should consist of, we need to think about what caused the speech problem, the severity of the problem, the specific areas of speech that are being affected, as well as the time and effort the client will put forth in therapy. For individuals with dysarthria, our job as the SLP is to facilitate the efficiency of communication, facilitate the effectiveness of communication, and facilitate the naturalness of communication. So how do we do this? Well, our treatment can be restorative, compensatory, and at times it may be preservative, meaning maintaining their speech functions. Restorative treatment focuses on improving speech intelligibility, their prosody, and the naturalness and efficiency through training or through teaching. Compensatory treatment focuses on improving the comprehension of the client's speech by increasing the client's use of communication strategies and possibly even altering the communication environment. Now here we may also need to increase use of AAC, augmentative alternative communication options. And one of your graded activities will be watching a video about AAC to help with this. Preservative treatment is for individuals that typically have a slowly progressing degenerative disease. And with this, we try to maintain what speech they have and continue to increase that use of AAC so they do have some means of communicating. When treating dysarthria, therapy is focused on the areas of speech production affected. It is important to sequence our treatment with respiration and phonation usually targeted initially or first. For respiration, the goal is to build or increase the physiological factors, and this may include volume, strength, and coordination. For strength, the treatment will focus on strengthening muscles that affect speech, such as the tongue muscles. For coordination, we're going to focus on practicing lip and tongue movements. Possibly for volume, we're going to work on improving breath support in order for them to be able to speak louder. And we also may work on breathing, specifically expiration as well as inspiration. Now, what about phonation? For phonation, there are two programs that could be used. LSVT, which is the Lee-Silverman voice treatment, and this focuses on improving loudness and intelligibility. Or you could do the PLVT, which is the pitch-limiting voice treatment, and that it works on increasing vocal loudness without increasing pitch. What about for articulation? Well, here we would teach the phonetic placement techniques that we've discussed with all of our other approaches. It may also be important to emphasize this phonetic placement and increase the precision through over-articulating or exaggerated articulation. Also drilling words, phrases, or sentences to repair or improve intelligibility. We could also do that. We also might need to target the client's rate of speech to improve their precision of clearer speech rather than it being slurred and mumbled like we had discussed earlier. Treatment for residents is a little different, though. Here you need to collaborate with, or you may need to collaborate with other disciplines, such as a dentist. Clients may need additional prosthetic support, such as a palatal lift prosthesis. For prosody, our goal is to increase the client's awareness and ability to control their rate, their pitch, and their respiration when using connected speech. We may also need to target stress using contrastive stress tasks to improve the naturalness, such as repeating sentences with stress being on different words. Another area may be to improve their intonation. Finally, when determining the activities to be completed in therapy, we want our tasks to be highly structured and repetitive. Drill work is key. Also, it is important to use trials that can be used for continued practicing. Now that concludes this PowerPoint. When you continue on within this module, you'll see that you have 2 graded activities. Those graded activities will be watching some short video clips. The first video you will watch shows the differences between phonological apraxia and dysarthria. And then the second video, as I mentioned earlier, is on AAC use.